Good morning. We'll talk about or we'll discuss EBV today, or Epstein-Barr virus, EBV. So EBV, Epstein-Barr virus, it is a herpes viridae. And regarding herpes viridae, remember for herpes viridae, they can cause latent infection. Okay, so once you have it, meaning you'll be a carrier for life now for that particular microorganism. Okay, so EBV, Epstein-Barr virus, and it is the causative agent of infectious mononucleosis. Okay, so this is the disease associated with EBV, and EBV is the agent of Cushing's disease. Okay, so Cushing disease, the agent is EBV because the major or the main mode of transmission of EBV is via saliva. Okay. Next is another disease associated with BVV. You have lymphoproliferative disorders. So disorder associated with the lymphocyte, or there's a problem with the uh, lymphocyte, and it can cause several malignancies. Okay. So later we'll discuss what are the uh, types of cancer associated with EBV. So the transmission of EBV, it's via intimate contact with salivary secretion. Okay, this is the main mode of transmission. Other ways, you have blood transfusion, organ transplant, sexual contact, and perinatal exposure. But this is the less frequent mode of transmission of EBV. Okay, so the primary, it is intimate contact with salivary secretion. That's why your EBV, it's the causative agent of kissing disease or EBV infection. Okay. The target cell of EBV, you have two target cells. You have epithelial cells and the B lymphocyte. Now, the the epithelial cells is usually present in the oropharynx, and the epithelial cells contain beta 1 integrin. Okay, so the surface of epithelial cells contain beta 1 integrin. And beta 1 integrin is the receptor of EBV. Okay, another receptor of EBV is the CD21 or cluster of differentiation 21 present on the surface of B lymphocyte. Okay, so you have two target cells. You have epithelial cells and the B lymphocyte. So for epithelial cells, you have beta 1 integrin as the receptor. And for B lymphocyte, you have CD21 as the receptor of your EBV. So first, the flow, okay, of the infection. First, you have the infection of the oropharynx. Okay, so the uh, EBV will invade the epithelial cells in the oropharynx. And after that, next is it will um, uh, spread to the salivary gland and tonsils. And after that, next is you have the infection of the B lymphocyte. Okay, so it will start with, or it will start in the oropharynx. Then the last ma-infected is you have your B lymphocyte. Okay, so that's the flow for your EBV infection. Okay, next, antibodies produce if you have EBV infection. So first is you have heterophile antibodies. Okay, so later we'll discuss what is heterophile antibodies. Cold agglutinin. So EBV infection is one of the causes of cold agglutinin production. Another cause or another antibody being produced in EBV infection, you have your rheumatoid factor, okay, and ANA or your anti-nuclear antibodies, okay. Then, since EBV is capable of latent infection, infected person is a carrier for life. Okay? Because EBV is capable of latent infection. So, mustay siya nga dormant, mustay siya sa sulod sa B lymphocyte. Okay? Sa imong lifetime. Okay? So, atong mga B lymphocyte nag-contain siya, or if you're infected with if you're infected with EBV, meaning na your B lymphocytes usually they contain um, EBV. and it will stay there for a long period. Okay, so you have latent infection, and meaning you're a carrier for life now. Okay. Next, the antigens present in EBV infection. So we have three antigens. You have early antigens, late antigens, and latent antigens. So for early antigens, you have EAD, or early antigens diffuse. Okay, D is diffused. Okay, R is restricted. Okay, so for diffuse, meaning the antigen is present in the nucleus and in the cytoplasm. Okay, so present in the nucleus and in the cytoplasm. For restricted, it is only present in the cytoplasm of the cell. Okay, the antigen. Okay, next is late antigen. So for late antigens, you have VCA, or viral capsid antigen. And for latent antigens, you have EBNA, or EBV nuclear antigen, and LMP, you have latent membrane protein. So these antigens are important because these antigens will trigger your immune system to produce antibodies. And we can diagnose EBV via antibodies. Okay, so we can identify whether the infection is acute, the acute the infection, or if there is a past infection or recurrent infection due to the antibodies present. And the antibodies are produced because of the antigen nga gina-expose or nga gina-introduce sa virus to our immune system. Okay? So that's for the use of antigen and antibody in the diagnosis of EBV infection. Okay, so you have early antigens, late antigens, and latent antigens. And your body will produce antibodies, and we can use the antibodies to diagnose the EBV infection. So if there's recent infection, past infection, or recurrent infection. Okay. Infants and young children, they usually are asymptomatic or will have mild symptoms of EBV infection. For adolescent and adults, usually they will develop infectious mononucleosis. So characteristic of infectious mononucleosis, there is fever, lymphadenopathy, and sore throat. Okay, so that is for infectious mononucleosis. Next, laboratory findings. So for laboratory findings of in IM or infectious mononucleosis, first, there is absolute lymphocytosis. Okay, so greater than 50% of total leukocytes, meaning there is leukocytosis, but the cause of leukocytosis is lymphocytosis. So lymphocyte is the dominant, okay, dominant white blood cell present in the specimen or in the blood film in patients with infectious mononucleosis. There is absolute lymphocytosis, okay, greater than 50% of the total leukocytes, okay. And there's the presence of your atypical lymphocyte, okay. 20% of the lymphocyte present is you have atypical lymphocytes, or your activated cytotoxic T cell, or your Downey cell. Okay, so the presence of Downey cell or atypical lymph, okay, atypical lymphocyte in infectious mononucleosis. And there's also the presence of heterophile antibody. So heterophile antibody is the screening test. Okay, we can use heterophile antibody as the screening test to detect infectious mononucleosis. So what is heterophile antibody? Antibody that is capable of reacting with similar antigens from two or more unrelated species. Okay, meaning this antibody is capable of reacting with horse red blood cell, sheep red blood cell, and bovine red blood cell. Okay, but it is produced by our body, human. Okay, human body. Okay, so the human heterophile antibody is capable of reacting with horse RBC, or it can cause agglutination with horse RBC, sheep RBC, and bovine RBC. Okay. Another characteristic of heterophile antibody is an IgM. Okay. And 40% of patients with IM usually will have no 40% of patients with IM will have heterophile antibody during the first week of infection. Okay. and 80 to 90% during the third week of infection. So usually, this heterophile antibody is sensitive in uh, detecting infectious mononucleosis. But it usually disappear. The heterophile antibody usually disappear 3 months after the onset of symptoms. Okay, so during the first and third week of infection, you can use heterophile antibody testing. But after 3 months, after 5 months, then the sensitivity of the test will go down now. Okay, so that's for heterophile antibody. So the presence of heterophile antibody in infectious mononucleosis. So for laboratory test, you have heterophile antibody test. So name is, you have Davidson's presumptive test. So Davidson presumptive test is the routine procedure performed to determine the titer of total heterophile antibody content in a patient's serum. Okay, and regarding uh, the differentiation of heterophile antibody, you can also use Davidson's differential test or DAT, and it is used to to it's used to differentiate the three heterophile antibodies. So later we'll discuss what are the three heterophile antibodies and how to differentiate using DAT. Next is agglutination in tube with a titer of 1:224 is a presumptive evidence of or for IM, okay, or infectious mononucleosis. So 224 is the significant titer for heterophile antibody test. Okay. Okay, so for the procedure of your Davidson presumptive test to screen or to determine the titer of heterophile antibodies, first you need 12 test tubes. Okay, so for the test tubes, 1, 2, 3, 4. I don't know. Let's delete this one na lang. So 1, 2, 3, 4, 5, 6, and so on. So for the first test tube, you need to place zero point 0.4 ml, okay, zero point 0.4 ml of NSS. Then for the second to from second to the 12th uh, test tube, we need to place 0.25 ml of NSS. 25, 0.25, 0.25, and so okay, 0.25 NSS. So these are NSS. Next is uh, after pipetting uh, or after adding NSS to the 12 test tubes. Next is to add um, patient serum. Okay, so for patient serum, you need to add zero point 0.1 ml of patient serum in test tube number 1. So the dilution for this test tube, it is 1:5. Okay, because the sample volume is 1 and 4 NSS. Okay, 1.1 and 0.4. And after that, mix, then transfer 0.25 from test tube 1 to test tube 2. So the sample volume for test tube number 2 is 0.25 because that's the volume you obtained from test tube 1 or transfer from 1 to 2. Then the NSS is 0.25 plus 0.25, total volume is 0.5. So the dilution is 1:2, but you need to multiply 1:2 with 1:5, the previous dilution. So the dilution for test tube number 2 is 1:10. Okay. Then next is transfer 0.25 from test tube 2 to test tube 3. Okay. So the sample volume, it's 0.25 because that is the volume you obtain or you transfer from from 2 to 3. Then the total volume now of this tube, it's zero point 0.5 because 0.25 from test tube 2 and the original 0.25 NSS. So this is 0.5. Okay, so dilution is 1:2, but you need to multiply this with the previous dilution, which is 1:10. So this one is 1:10. 20. Okay. The next is multiply this one. Oh, no. Transfer 0.25 from 3 to 4. Okay. From 3 to 4. So 0.25, that is the sample volume because that's the amount of fluid you transfer from 3 to 4. Okay. Then over 0.25. No. The original volume in this test tube is 0.25 plus 0.25 from test tube 3. So it's 0.5 total volume. So 1 is to 2. So 1 is to 2 times 1 is to 20. That's 1 is to 40. So 5, test tube 5, that's 1 is to 80. This one is 1 is to 160 and so on. Test tube 12, that is your negative control. So in test tube 11, you need to dispense or discard 0.25 ml from test tube 11 so that your test tube number 12 will be a negative control. The next is to add SHIP RBC suspension. So it's different from your cold agglutinin because in cold agglutinin, you're going to use patient's RBC suspension. But for heterophile antibody, you're going to use SHIP RBC. Okay, SHIP RBC because we're testing for heterophile antibody, di ba? Ang heterophile antibody is an antibody that is capable of reacting sa different species like horse RBC, sheep RBC. So, the next reagent that we're going to use is sheep RBC suspension. Okay? So, the volume of RBC suspension that we're going to add to tube number 1 is 0.1. Okay? 0.1 RBC suspension. Now, regarding the sample volume for test tube number 1, the sample volume is the remaining fluid before you add the RBC suspension. It's 0.25, di ba? Because you transfer 0.25 from test tube 1 to test tube 2. So, the sample volume for test tube 1 is 0.25. But the total volume is, so 0.25 plus 0.1 RBC suspension, that is 0.35. So, 0.35 divided by 0.25, that is 1 is to 1.4. 1.4. So 1 is to 1.4 times the previous dilution, which is 1 is to 5. The final dilution of test tube number 1 is 1 is to 7. Okay? 1 is to 7. Okay. Next, for test tube number 2, we also add 0.1 RBC suspension, SHIP RBC suspension. The original volume in test tube 1 is 0.25. Then, total volume, 0.25 plus 0.1 RBC suspension, that's 0.35. So, 0.35 divided by 0.25, that is 1 is 1.4. So, the current dilution is 1 is to 1.4. So, the current dilution times the previous dilution, which is 1 is to 10, the final dilution of test tube 1 is 1 is to 14. Okay? 1 is to 14. Next is test tube number 3. This one is you add 0.1 RBC suspension, SHIP RBC suspension. The original volume it's 0.25. That's the sample volume. Total volume it's 0.35. So same, it's 1 is to 1.4. Okay, so 1 is to 1.4 times 1 is to 20. This is, let's compute it, 20 times 1.4. It's 28. So this one is 128. Okay, so 28 times 2. This is, so for test tube number 4, it's 156. Okay, now to determine the titer, okay, so after adding RBC suspension to all test tubes, next is you incubate this one at room temperature for 2 hours. After 2 hours, you centrifuge the tubes for 1 minute, and after 1 minute, you check for agglutination. So for the titer, it is the tube, it is the dilution, the highest dilution with agglutination. So for example, you have agglutination for tube 1, tube 2, and tube 3. So the titer, it is 28. And the significant titer for heterophile antibody, it's 28. Okay? So for example, after centrifugation, you have agglutination test tube 1, test tube 2, test tube 3, test tube 4. Then the titer for the heterophile antibody, it's 56. Okay? So that's for your heterophile antibody test. Okay? So this is your Davidson presumptive test. Okay, so regarding diagnosis of infectious mononucleosis or EBV infection, 'di ba? The presumptive test or screening test, you have your heterophile antibody. Okay. The diagnostic test, you have your EBV antibody. So these are the antibodies produced against the antigen being produced by the virus. Okay. So the by example of the antigens, you have early antigens, EA, it's either D or R or diffuse or restricted. The next is you have your VCA or viral capsid antigen. Then for uh, latent phase, you have your EBNA, EBV nuclear antigens. Okay. So for definitive diagnosis or diagnostic test, you have your EBV antibodies. So for the method to determine EBV antibodies, you have your ELISA, which is the preferred because it's less time consuming. But the gold standard in EBV antibodies measurement, it is IFA or indirect immunofluorescence assay. Okay. So next is you have your antibody profile, EBV antibody profile. So for antibodies, for current infection or recent infection, you have positive EBV VCA IgM and also the positive anti-EA. Okay? So VCA IgM or anti-VCA IgM antibodies is diagnostic for current or recent infection, and it is the most useful marker for acute MI or recent infection. MI, not MIIM, infectious mononucleosis, or it's the most useful marker for EBV, recent or current infection. Okay, so for recent or current infection, you have anti-VCA IgM or IgM anti-VCA and anti-EA antibodies. Next is relapse of previous infection or recurrence or recurrent infection, so nibalik. So you have positive EA and positive anti-EBNA. Okay. So positive anti-EA and positive anti-EBNA, that indicates relapse of previous infection, okay, or recurrence. Next is for past infection, you have positive EBV VCA IgG, so IgG anti-VCA and the presence of anti-EBNA, okay. So IgG VCA anti-VCA, that's an indicator of past infection, okay. Then positive anti-EBNA, positive anti-IgG, anti-VCA without IgM, that's an indicator of indefinite past. But if there's a presence of IgM, okay, IgM indicates recent, okay. So for relapse or for chronic active infection, okay, so active chronic infection of infectious mononucleosis, usually you have this one, EBNA, VCA, and you also have EA, okay, if there is chronic active infection. But for past infection, you have anti-EBNA, IgG, anti-VCA, then wala ang IgM. Because ang IgM, appear lang siya once there is recent infection. Okay? Then next is VCA peaks 3 to 4 weeks after infection with IgM not detectable in 12 weeks. Okay? In 12 weeks time, you have the production of anti-VCA, IgG anti-VCA, not IgM anti-VCA na. Because IgM is for current or recent infection. Next is for chronic active EBV infection. So for chronic active EBV infection, usually the antibody profile, you have positive anti-VCA IgG. You also have positive anti-EA and positive EBNA. Okay, this is for chronic active EBV infection. Chronic, long term. So this is a severe type of EBV infection, and usually life-threatening IM-associated symptoms persist or recur for more than 6 months after the acute illness. Okay, and in chronic active EBV infection, it's associated with malignancies. So you have Burkitt's lymphoma, Hodgkin's disease, nasopharyngeal carcinoma, and gastric carcinoma. So in chronic active EBV infection, the EBV, uh, the virus, uh, kaya naka-integrate na siya sa DNA. Okay? The virus is integrated na sa DNA of the lymphocyte. Okay? Or the target cell. The target cells, diba, you have your lymphocyte and epithelial cells. So the EBV, kaya na-integrate na siya sa target cell. And that integration causes the appearance or the development of cancer cells. Okay? So since the lymphocyte is one of the target cell. That's why there is Burkitt's lymphoma. And another is, diba, another target cell, you have your epithelial cells in the oropharynx. That's why there is nasopharyngeal carcinoma. Development of nasopharyngeal carcinoma in chronic active EBV infection. Okay, so I think that's all regarding EBV. Okay, so EBV is the causative agent of infectious mononucleosis. Agent of Kissing's disease. The mode of transmission, primary, it's being in contact with salivary secretions or saliva. Then there's the production of heterophile antibody, and you can use heterophile antibody as diagnostic test. Presumptive test for IM or EBV infection. But the definitive or diagnostic test, you have the EBV antibodies. Okay, so regarding EBV, it's also associated with different cancers. So cancer sa lymphocyte or cancer sa epithelial cells present in the oropharynx, because the epithelial cells and B lymphocyte are the target cells of your EBV. Okay, so I think that's all regarding EBV. Thank you.